Good evening, everyone. I'm Marcia Stedman, President of Healthcare for All Washington, and we're going to begin our second Wednesday speaker series. Thank you for joining us tonight, and welcome. Tonight, we are very fortunate indeed to hear Vicki Lowe, Executive Director of the American Indian Health Commission of Washington State. She'll be speaking on tribal sovereignty and Indian healthcare. Now a little bit about Ms. Lowe. Vicki Lowe has been the Executive Director of the American Indian Health Commission for Washington State since July of 2015. She's a Jamestown S'Klallam descendant. She has worked in the health department of the Jamestown S'Klallam tribe since December of 1996, where she's seen many changes in the private insurance world, as well as Medicare and Medicaid, as she secured health insurance for tribal members who had no coverage since 1995. She's also participated in the Basic Health Sponsorship Work Group. She negotiated a tribal member-only plan with a commercial carrier, initiated contracting with commercial carriers at the Jamestown Family Health Clinic, participated in the creation and implementation of the Jamestown S'Klallam Tribe Employee Plan, which is a self-funded plan, and worked with Jamestown S'Klallam Tribe's newly created Human Resources Department to review and update benefits for the employees' plans, implementing the Indian provisions of the Affordable Care Act into the employee benefits program. Beginning in 2012, when the Affordable Care Act went live, she began working to implement the Tribal Assister Program for the Washington Health Benefits Exchange. This project has been expanded since to include Medicare, Medicaid, and the Indian Health Service Benefits training. Vicki's also branched out from healthcare to be a member of the Washington State Women's Commission. This is since 2020. As you can see, Ms. Lowe has a wealth of knowledge about healthcare, health insurance, and the needs of the American Indian community. From 2019 to 2020, Ms. Lowe represented the tribes of Washington State on the Universal Healthcare Work Group, adding immeasurably to their discussions. Her valuable contributions and those of others led a majority of workgroup members to recommend a publicly funded universal healthcare system for Washington, and to further recommend that the next step be drafting legislation to establish a universal healthcare commission charged with designing the plan. The legislation, known as State Senate Bill 5399, passed both chambers of the legislature and was signed into law this year. The commission is now being set up and will hold its first meeting this October. These meetings will be open to the public, so please watch our website for meeting information and how you can be involved. Ms. Lowe has also been very involved in the Jamestown S'Klallam tribal community, you will see. She has been part of the Jamestown canoe family since 2009, pulling in the tribe's canoe since 2012. She supports singing and drumming, language, weaving classes, and other cultural programs. And in 2012, she was honored as the Jamestown S'Klallam Tribe's Volunteer of the Year. Most of all, she enjoys spending time with her family, husband Jim, 5 children, and 4 grandchildren. We're deeply honored that Vicki's been able to join us this evening. Please welcome Vicki Lowe.
Thank you, Marcia. Hi, Squatchy. Good evening. And let me see if I can share my screen. And thank you for inviting me. I mostly do presentations to managed care organizations and people who I'm trying to get to understand better why they should work with the Indian healthcare providers. So it's good to talk to people who really support, universal healthcare and healthcare for all. I think there's a lot of misunderstandings about how healthcare coverage works for Indian people. And so that's what I kind of want to help you all learn to understand tonight, and the importance of the inclusion of American Indians, Alaska Natives in any universal healthcare bill. By the end of the presentation, I hope that you understand why. And I think we're just going to do questions at the end. Is that right? Okay. And I always like to start by doing a land acknowledgement. I just want to let you all know that you don't have to be Native to do a land acknowledgement. It's important that we understand that all this land that we live on really belongs to the Native people who it was taken from. So today I am here on the home of my own ancestors. So I would like to begin by acknowledging, as we gather today, we are all on the ancestral homes of Indigenous people. Where I live, that is the S'Klallam people who have lived in these lands from time immemorial. Please join me in expressing our deepest respect and gratitude for our Indigenous neighbors, the S'Klallams and other Salish people, for their enduring stewardship of the land and protection of our shared lands and waterways. New S'Klallam means S'Klallams, and the S'Klallams are the strong people. A little bit about the American Indian Health Commission, where I work. It is a nonprofit that was actually put together by the tribal leaders in Washington State. And I'm going to talk a lot about the federal relationship of tribes, but in the early 90s, the tribal leaders in Washington State realized that they had to figure out how to work better with the state governments, especially on healthcare, because the decisions made by the state agencies and the legislature were impacting access to care for our tribal members. So in order to understand how all of that works, we need to first talk about tribal sovereignty, and then I will talk about the Indian healthcare delivery system. Both are really complicated, so please consider this a high-level overview. So understanding and respecting Indian law can only help all of us provide better care to Indian people. And it is important that we improve the healthcare of American Indians, Alaska Natives, because they suffer from some of the greatest health disparities in our state. So in order to talk about Indian healthcare, I really have to go back to the foundations of the Indian healthcare delivery system and the legal justifications for them, which is different from healthcare for probably anybody else in this country. So it's important that we, as I mentioned earlier, that we think about whose land we are all on. And prior to contact, this is where all the Indian tribes were located. And I just want to say, I say Indian a lot in my presentations because the federal word is Indian tribe. And so some people find that offensive, and I apologize if that offends you. I was an Indian growing up, so it doesn't bother me as much, but Native or Indigenous, whatever feels comfortable for you. Somebody has their hand up, I don't know. Keep going. Somebody.
Keep going. We're going to be asking people to put their questions in chat if they have a question. Okay. Or if it's any other matter, put it in chat. Thank you.
So just kind of keep a picture of this mind in, or this map in your mind, as because we'll get to why it's important. So sometimes when you want to understand something, it's best to find something that is like it, that you might know. So federal Indian law is really close to, can be really close to international law. So prior to the United States actually being a country, the tribes on the East Coast of that map there, they were negotiating treaties with Great Britain and Spain. And this really established them as nations prior to the United States becoming a nation itself. But when it did, you know, the United States used treaties in the beginning to try and encourage trade and establish good relationships with the Indian tribes. However, over time, the treaties became a way to take land from Indians. In between 1789 and 1871, 390 treaties were negotiated between the US government and Indian tribes that were on this land. And then as the administration changed federally and there was the westward expansion, treaties were negotiated differently. By the time they got to Washington State, Andrew Jackson was president, and the policy for treaty making really changed into a way to just open land, take it away from Indians, and to give it to settlers. So by the time all the treaties were negotiated and Indian people were sent to different lands, these green and blue places are where the Indian people were left. So many of our ancestors did not survive the first contact, and the effects of being moved away from their land and settled onto different reservations. And just a note, when I talk about this stuff, it is not about shaming anybody about what happened. It is about talking about the real history and understanding how the real history puts us in the position we are today. So in Washington State, all the 8 treaties that were negotiated within 2 years. And if you look at all of them, we've highlighted in blue here, so you can note each of the treaties in Washington State included the provision of health care in trade for the land that was given up. And then something really important, because I hear people say a lot who don't understand Indian law, that treaties were a long time ago. It's, you know, they're over. We shouldn't be continuing to keep those things in place. You know, tribes should be paying taxes, the healthcare shouldn't be happening, and those kinds of things. And these are really hurtful, because actually, when Congress decided not to make treaties anymore in 1871, they did in law, so this is 25 United States Code 71, provide further that nothing herein shall contained shall be construed to invalidate or impair the obligation of any treaty lawfully made. So since 1871, they stopped making treaties, but the treaties that were made have been upheld. And remember, many of those treaties included the provision of health care. In Washington State, right now we have 29 federally recognized tribes. And I love this picture because it really shows the differences, you know, how unique each tribe is. They put in their logos, the things that are important to them. And so we have 29 tribes in Washington State, and we like to tell people, if you met one Indian tribe, you've met one Indian tribe. You can't really say that you know what is like for all of the tribes, because you've met one tribe. They are unique and different and similar in some ways. So it's also, let me go back. Also important to note that there are tribes that aren't federally recognized within Washington State, and you might know of some of them. There's the Duwamish tribe, whose land was the city of Seattle, the Chinook tribe down in the Southwest Washington. And these are tribes that are fighting for federal recognition, and we're really hopeful that with the new administration, the Biden administration, they'll be able to get there. The Duwamish tribe was federally recognized at the end of the Clinton administration. I think their chair said it was 7 days. And then when the Bush administration came in, they called and said, sorry, we take it back. And these are the kinds of things that happen to tribes and that really undermine a lot of the relationships and that we have with the federal government. So there's 2 important themes from Indian law. And the first one is tribal sovereignty. And so tribes are independent entities with the inherent power of self-government. Now, the word inherent means that they've always had it. And think about that. Think about those lands on that map where the tribes were before people came. And think about how those tribes had their own governance structures. They may not look like what you see today, but they took care of their communities, which is really what I feel is a function of government. And they had sovereignty. They, you know, took care of each other. They fed their communities. They decided when to move according to where food was and those kinds of things. So that is the beginning of tribal sovereignty. So as soon as the federal government started making treaties with the tribes, there were problems. So, and all of them really came to a head in Georgia with the Cherokee Nation. So There are three very important Supreme Court decisions made by Justice Marshall, not Thurgood Marshall, but John Marshall. He was one of the first Supreme Court justices when the Supreme Court was really young. And so the first one is in 1823, and it is Johnson versus, I can't always say it right, Mintosh, which I assume is an Irish or a Scottish name. But in this case, the treaty had been signed and the Cherokee people had moved to the reservation land, and one of those Cherokee people sold part of their land to a non-native, to a white person who wasn't living on the reservation. At the same time, the federal government gave that same piece of land to a different non-native person. And so this Supreme Court case was really about who owns the land. And what Justice Marshall determined was it was actually the federal government who owned the land, that upon discovery of the Indians here in the United States, that they lost their complete sovereignty as an independent nation, only to retain the right of occupancy of their land. And this is how reservation land still works till today, that the tribes don't technically own it. The federal government owns it, and it's in a trust and trustee relationship. The second Supreme Court case was when the state of Georgia was trying to exercise jurisdiction by creating laws that govern the Cherokee people. And what was established in this decision was that the tribe was not a foreign nation, but they are a domestic dependent nation, which is some strange wording. And so they're subject to the sovereignty of the United States federal government, but not the state government. And that's a really important concept that still holds today. And then the third one is Worcester versus Georgia. The justice ruled that the tribal sovereign powers were not given up when they signed treaties, and that the tribe continued to be sovereign and should be governing their own people. And the line at the bottom is a really important line from that decision. And I want to point out that I don't know, can you see it with I've got the thing in the way, but it talks about the undisputed possessors of the soil. So they're again talking about the land and the importance of land to Native people. Oops. So sovereignty is an inherent power. In contrast to like a city, they get their power from the state. A tribe's power existed before the federal government existed. So that is really what we mean by inherent. We see tribal sovereignty all the time. We talked a little bit about it in the past, but in the last year during the COVID response, we've seen tribes exercise sovereignty over their people, choosing to close down their borders, to do case and contact tracing with their own people, to administer vaccines based on their own priority for who should be vaccinated, and including people who weren't tribal members because they consider them part of their community and made them a priority because they impact the health of their people. Tribes also define who can have membership in the tribe. They have their own legislation. They're often called codes and constitutions. Some tribes have their own law enforcement, and some tribes even impose some taxes on their people. So there's a treaty responsibility for healthcare, or just for taking care of the tribes, but also it became a trust responsibility. So it's a legally enforceable obligation of the United States to protect tribal self-determination, which we'll talk a little bit about, tribal lands and assets, resources, and treaty rights. So if you, an example is if someone were to sue a tribe, the federal government comes in and takes over for them in the case, and then you're actually suing the federal government. And that's the kind of trustee relationship that was established in that Supreme Court case with Justice Marshall. So the federal trust also includes that treaty responsibility to provide health care. Here's the wording from the Treaty of Point Elliott, which literally says that they will employ a physician to reside at the central agency that will furnish medicine, and it includes vaccination. Vaccinations were really important back in the day when it came to smallpox, and they're still important today to us. And then in the 70s, the Indian Healthcare Improvement the Indian Healthcare Improvement Act was passed, and that was the first time in federal law that the responsibility to provide healthcare was talked about as being directly to the American Indian people and not just the tribe. So that is a really important concept today still. We'll talk about that when I get to the Indian healthcare part. So there's 5 important federal Indian healthcare statutes. So healthcare went from treaties, and now we're going to see it become federal law. So the Snyder Act in 1921 was when the federal government first started to realize they weren't really keeping up their agreement, and how the relationship works with the federal government ebbs and flows based on who's the president, basically. But the Snyder Act is the first time there were appropriations to provide health care to the tribes. And then in 1975, and this was actually Nixon, the Indian Self-Determination and Education Act was passed, and that was the first time where the federal government started to realize that it was important to really support tribes taking care of their own people. And this law actually allows for a tribe to draw down funds from the federal program that might have been run by Indian Health Services or the Bureau of Indian Affairs and run those programs themselves, which is self-determination. And then I mentioned this already, but the Indian Healthcare Improvement Act not only added, the language about healthcare for individual Indian people, but it also is the funding mechanism for almost all the appropriations that flow through Indian Health Services to the tribes now. In 2010, the Patient Protection Affordability Affordable Care Act, ACA, Obamacare, whatever you call it, it reauthorized the Indian Healthcare Improvement Act, but it also had quite a few protections. Some people call them special protections. I call them appropriate protections for Indian people. And so because the Indian Health Service is so underfunded, the Affordable Care Act says that members of federally recognized tribes don't have to pay co-pays if they're on a qualified health plan in the exchange. They didn't have to pay the I already forgot what it was. The tax for not having coverage because Indian Health Services was considered comparable coverage. And again, so this law also permanently reauthorized the Indian Health Improvement Act, which we were worried about because it had gone past authorization during the Bush administration. And so the Obama administration made good on it. And then we didn't have to worry about the appropriations every year. So that brings us up to the Indian Health Delivery System. And I'm gonna give a pretty high-level overview. In 1955, Indian Health Services was established. Prior to the establishment of the Indian Health Services had been in the War Department and then the BIA. And so it's separate from the Bureau of Indian Affairs, and it falls under the Department of Health and Human Services. So it's a sister agency to CMS. And it provides a funding mechanism for healthcare for 2.2 million eligible American Indians, Alaska Natives. And there's a legal definition for who is eligible for Indian Health Services, and it's persons who are of Indian descent or a member of a tribal community. There are 3 kinds of Indian healthcare providers, and this is where healthcare starts getting complicated. There are Indian health facilities. So those are facilities that are still run by the federal government. There are tribal compact or contract facilities, and those are facilities that contract those funds down from, like I said, from the Indian Self-Determination Act. And then there are the urban Indian health care providers, and those are for urban areas where tribal people were encouraged to move to leave their communities. And this is upheld by that, the part of the Indian Health Care Act that talks about the right to healthcare being directly to Indian people, and they're providing the care under that part of the law. In Washington State, this is where our tribal clinics are located. The green pluses are tribally operated clinics, and the black with the white are the IHS facilities. And you can see there are a lot more tribally operated clinics than the IHS facilities. And then the blue diamonds are the two urban clinics, one in Seattle and one in Spokane. So the IHS direct facilities in Washington State, we only have 3 of them left. All of the facilities used to be IHS run, but as tribes took over through that Self-Determination Act, they became tribal clinics. And so there's one in Colville, one in Spokane, and one in Yakima. So they're all on the east side. The tribal compact clinics under the Self-Determination Act, there are 27 of them. And so most of the funds that come through Indian Health Services now come directly to tribes under those contracts. And these clinics provide direct care, but they also provide contracted care. And then the urban Indian health programs. So the Indian population in Washington State is 71% of it does not live on tribal land. So many of the Indian population in Washington State is not eligible for health care through an Indian Health Services or tribal clinics. So many receive through the urban Indian health programs, but there are a lot of American Indians, Alaska Natives who aren't connected to the Indian healthcare delivery system in any way. So in Washington State, we have Seattle Indian Health Board in downtown Seattle and the Native Project of Spokane and Spokane. So here's like the one similarity I can give you for the tribal clinics and the IHS clinics is that they have direct care dollars that are spent on providing care at the clinic. So it's whatever they have, and it's different at every tribe. Some tribes only have a doctor or a nurse practitioner. Some tribes have vision care and physical therapy and all those things. So it really is dependent on what the tribe is able to provide. But anything that can't be provided at the tribal clinic is referred out through a program called Purchase and Referred Cares. And so other areas, we're in the Portland area of IHS, other areas have IHS hospitals that you can refer to. But here in Washington State, we're really dependent on non-Indian healthcare providers for hospital care and specialty care. And that is where a lot of the money and a lot of our work goes. And just to give you an idea how the funding looks for Indian Health Services, these are from 2018. This was a report done by the Government Accountability Office. This shows the average spent per person per year on medical care under these different federal programs. So if you look at Medicare, it's over $13,000, but you look down here at IHS, this went all the way over on the end, it's $3,779 per person per year. So that is what is funded through IHS and then through these contracts. And so that's what the tribes have to work with for each of their tribal members to provide care. I'm going to skip through this pretty quickly. The government-to-government relationship is established through an executive order from President Clinton, but it's also established in some of the federal programs. In Washington State, we have the Centennial Accord, which is what our leaders wanted to have, which is more like kind of like a treaty with the state of Washington. And so there's a really formal government-to-government relationship between the Washington State tribes and the governor and the state agencies. In 2012, it was codified, so it's part of the revised Code of Washington, how that relationship works. And then what I really wanted to talk a little bit about is, all these things, the complicated care, the taking of the land. We didn't even talk about residential schools, but and the stealing of the culture and children from parents. All those things, have manifested into kind of the nexus where adverse child effects, meets historical and intergenerational trauma. And so we have some really high health disparities. And in Washington State, they're pretty high, higher than some other states. And, it becomes cyclical and carried on down through families. And I don't know how much you know about intergenerational trauma, but I know there are things that my body physically reacts to that surprise me. And it's part of that trauma. And I think, as you know, there's a lot of, through trauma, there's a lot of self-medication and behaviors that are dangerous that cause our people to die young. However, we're still here and we've survived all that. And the reasons for that are things we refer to as protective factors. We have community and culture and spirituality, and those help our communities thrive. We have great leadership, our tribal leadership all across the nation, but in this state is really caring, and they have that long vision, what we call 7th generation thinking. And it's important to have attachment and belonging. A tribe is basically an extended family, and we're taught to respect our elders, and grandparents are teachers, and aunties and uncles are disciplinarians, and who reinforce proper behavior. And these are all good things in our communities. We also have this idea that generosity is actually a symbol of wealth. So sometimes if somebody's giving away all their things, you think they might be suicidal. But for a Native person, if I have enough for myself, that's all I need. And then I give the rest to those who need it. And that's a very important protective factor. And it makes it hard to live in the rest of the world when it doesn't work that way. And so one of the things we really have this need to strive for the balance to make sure that everything gets what they need and gets the attention they deserve. And, I think of my relationship in the world as like, if I'm here, every time I do something, it affects things, and I have to think about how I'm affecting those things. So we're all connected, and we really have to think about that. So that's what I have for you tonight. I know it was really kind of a quick and high level overview, but I want to stop and give a chance for questions. I just really want to thank you for being here and listening. I know it's like a really nice evening. You could be sitting down at the water, enjoying a cool breeze.
Thank you. Yes. Well, we can go down to the water later, but this has been a really valuable part of our evening, my evening anyway. I've been curious about many of these things, and this is just the beginning. And we'd love to have you back at another time and maybe go into more detail about some of these
I can talk
topics.
for hours, so
Good.
Ask your husband, he'll tell you.
Okay, well, we are a little bit ahead of schedule, but let's move along. We'll have more time for questions. So I would like to now hear from Peter Lucas. He's the chair of our fundraising committee, and he has a few words to say on fundraising's behalf. Peter?
Thank you, Marcia. I bet most of you thought you'd get away without a fundraising pitch, but no, that's not going to happen. I'll make it short. As you know, our organization has had many successes in the past few legislative sessions. You can go on the website and learn all about them. For instance, we were the driving force behind the Universal Healthcare Work Group. We had 7 of our members in that group. Their work led to the creation of the Universal Healthcare Commission, which is in the process of being set up right now. It's tasked with creating a system to provide healthcare for all Washington residents. And they could craft, we hope, a single payer system based on our bill, which is the Washington Health Security Trust, which we've had in the works for over a decade. But in order to maintain our momentum, it is vitally important that we grow our membership, educate the public, and mobilize our supporters to spread the word to their family, friends, and most importantly, their legislators. And we can achieve those goals through social media, monthly webinars, meetings with civic groups, and by hosting other events. Tonight's presentation is an example of one of our monthly webinars. And hopefully we will be able soon to get out from behind our laptops and smartphones and meet with people in person. We have some meetings planned with some donors. And in addition, we have a paid employee and other fixed costs. These activities and obligations all require funds, which is why we are asking you to donate tonight. As Marcia mentioned at the beginning, our goal is $300 for tonight. So please go to our website and click on the donate button, and you can find links to our website in the chat. And you can make a one-time donation, but what we'd really like to see, we really encourage you to do is make a monthly recurring donation, which will really help us to keep the ball rolling. And I liken it to a Netflix subscription, except you might get universal health care instead of movies. So please donate so we can spread the word and bring about universal single payer health care in Washington. Thank you.
Thank you, Peter. And I know I saw the donate URL in the chat, so I encourage people to go there and give what you can. We have other opportunities like volunteer opportunities. So while you're on our website, you could also check the Get Involved tab and see if there's something that we need that you can do and you would love to do. We'd love to have your energy with us. So we can now move to the questions and answers. Gigi Davidson is one of our newer volunteers, and she's ready to start asking the questions you've typed into chat right now. Gigi, what do you have for us?
Hi, everyone. Let's see, I'll just kick it off right now. So the first question I'll actually ask is from Ronnie, and he asks, what gives you hope in these times of pandemics, inequity, and injustices in the world?
Oh, a lot of things, you know, like I said, we're still here and we have all those great protective factors, but they're also starting to be recognized. And with the new administration at the federal level, they're actually interested in many of our best practices and funding things that aren't evidence-based practices, because, you know, if you're from a race of a small number, the evidence is never based on you. And through the COVID response, I think the best story that I hope gets told is how the tribes came together and helped each other and helped to make sure that their communities got vaccinated. Our way of caring about communities, I think, is the best way to do things. And I hope that that lesson is shared, and that gives me a lot of hope.
Yeah, that's really nice to hear. Let's see, I'll move on to the next question. So let's see, this question is from Nora and Chris. So how much support for state-based universal health care exists within Washington's tribes?
There's a lot of worries about it, I can tell you that, because we have a very delicate balance for how we finance things, and we use Medicaid and Medicare. Actually, more Indian healthcare services are funded by Medicaid and Medicare than they are by IHS. So we're hoping that whatever is in place, and I applied to the Universal Healthcare Commission because I want to help make sure that that it's carefully done when it is considered tribes. But we're also worried about our tribal members who don't live near a tribal or Indian health services or urban clinic and don't have access to care. And so we know that universal health care will help our relatives who are away from care. And so that is also important. So it's a balance.
Okay, yeah, that actually brings me to my own personal question. So it's kind of a clarifying question. So the question is, if you are a member of a tribe, that means you can get coverage in some form or another through IHS. Is that right?
Yeah, I wasn't very clear about that. So IHS looks at your eligibility based on geography. So if you live on or near a reservation, and if that tribal clinic is open to more than just their own tribal members, then you can be seen. At the urban clinics, you can be seen for direct care, but if you have to go outside for care, they don't have those purchase and referred care dollars, so you have to have coverage or pay for your own specialty care.
Okay, so if you go to an urban clinic, then you have to be a member of the tribe.
To be a member of a tribe or eligible for Indian Health Services, which is a descendant down to like my grandson would be eligible if I were an enrolled member of a tribe.
Okay. Okay, cool. That's oops, I accidentally muted myself. All right, so the next question, okay, is from Marcia. How do the currently recognized tribes view the tribes that are not recognized and trying to gain that recognition?
That's a tough one because, you know, how the federal government kind of plays us against each other is they tell us if, you know, a tribe is recognized, we only have so much appropriations, not entitlement, but appropriations of dollars, and that they would take out of that and give to the tribe. So they try and pit us against each other, but we're on to them. So for the American Indian Health Commission, we're starting to include the non-federally recognized tribes in the work that we do. So we started working with the Duwamish tribe. We just did a vaccine clinic with them over in Burien, and we're reaching out to the Chinook tribe. And then we're working with the Urban Indian Health Institute, which is part of Seattle Indian Health Board, to try and find the other tribal people who live in the state but don't have access to care, that aren't connected to a clinic, but they're hard to find. But to answer your question, sometimes it's not good. But also we know what they feel like, so we need to like step up and do our part in equity too, and make sure that they get federally recognized.
Yeah, definitely. Okay, that's interesting. Okay, let's see, digging through this question. Okay, so this is from Rich. So when a Native person utilizes healthcare providers that are not part of the IHS or tribal clinics, do they have problems getting their care paid for? Do Natives get burdened by healthcare debt, or does it always get paid for by tribal and IHS sources?
We're getting better at it, but when IHS did the purchase and referred cares, they had a lot of rules, and a lot of times Indian people would get stuck with specialty care bills or hospital bills. We have to sign people up for Medicaid sometimes and Medicare to make sure that they have that coverage. But there's not a very good understanding of Indian healthcare because it's different at every tribe. So if you go to a different clinic, they might have different rules and you don't understand them and end up with bills. Dental bills are a problem too. But yeah, that happens a lot for specialty dental care, which is pretty expensive.
Okay, yeah, so is dental like not covered?
If there's a dental clinic, but if, you know, they can only do what they can do. That's why we're really supportive of the dental health aid therapists, get plug in for them.
On that note, I guess, is like vision covered too, or is it just primarily, you know, medical?
Usually under the purchase and referred care program. I know that the Tulalip tribe has a optometrist that comes in once a month or once a week, and they have glasses to pick from. So it kind of depends on what the tribe's able to manage. Okay. And some tribes put in a lot of their hard dollars, which come from, you know, their casinos and hotels and resorts, into healthcare to provide those extra things.
Okay, that makes sense. It's interesting. Okay, and the next question is from Kathy, who says, so she says, I'm a retired home health nurse, and she was given the privilege of helping care for members of the Spokane tribe due to lack of enough tribal members to care. They were without a doctor on many occasions, and needs were so great, like there was a lot of cancer, and wondering how they're doing as I am in Seattle now. Wonderful people, I learned so much about Native life on the reservation. So would you happen to have anything to say about that?
They still have the IHS clinic there, and then they have their health programs. They have had a doctor, and that happens with tribes a lot where, you know, it's not easy to recruit somebody to live out Mia Bay or Quileute, or the Spokane reservation is pretty far out and not really connected. But they work a lot with the Native Project in Seattle, and the Native Project, or Seattle in Spokane, actually sees a lot of members of Colville and Spokane tribe in their clinic in Spokane when they're not able to provide care at the tribal clinics.
Okay, so it seems like there's other sources for.
Yeah, I mean, we're always working and trying to make things better.
Yeah, definitely. Okay, let's see. I think, did I get all the questions here?
Somebody had their hand up. Oh,
Hand up earlier, yeah. Okay, so
oh,
Peter just sent out a question.
that's a great question.
Yeah, so what do you see as cultural challenges that non-native providers have treating tribal members? That's a good question.
Well, first of all, the lack of understanding of Indian health services and how things will get paid, and that we have to sign up people up for Medicaid and use that first is always a problem. But once you get past that, you know, that there's usually a lot of tribal families will have one person who's like, you know, like an auntie or a grandma that like maybe goes to appointments with them. And ever since the HIPAA law, we've had a lot of problems with providers not being willing to understand that it's okay to talk if you know, that family member's there. I know even when we started our own clinic, we had some non-native doctors who didn't understand some of our traditional practices that our families did that were handed down, you know, like garlic for ear infections and those kinds of things. And they kind of made fun of some of our tribal members. I think people are a little more accepting of traditional medicine now, but still not understanding it. And then also the trauma from the intergenerational trauma sometimes makes it really hard to build a trusting relationship. So the lack of communication and not looking directly in the eyes and stuff is just kind of a little bit cultural, and also becomes an issue. And so people sometimes don't understand what their care is supposed to be, don't feel like they got treated, or maybe the provider doesn't feel like the person was listening, but they were.
Okay, yeah, that's interesting. Yeah. Okay, so the next question is from Elaine, and it's why are less healthcare dollars per person going to IHS, and what are some possible solutions?
Why indeed? It's, you know, it's how you erase people. Tell them you're going to give them something and only give them part of it. Every year there's something called Indian Health Services budget formulation, and it's this huge complicated way they figure out how they're going to not fund us, basically. Every year the tribes through the National Indian Health Board propose a process for the federal government to fully fund Indian Health Services, and we're actually starting to see some movement on that. We have like an 8-year plan to get them up to full funding. It's not like we're saying tomorrow you got to fund us, you know, we're trying to be reasonable. And, you know, the last 4 years, nothing happened. But in the Obama administration, we were starting to get somewhere. And I think with the Biden administration, we might actually get there. Everything's different now with, you know, all of the equity and justice and people really understanding, and then this administration. So we're hopeful, but it's basically to make us go away, you don't fund it.
And I guess kind of going off that question too, that this just popped to mind. So, you know, I know that health outcomes on tribal land and you know, tribal members are really bad. And, you know, there's a lot, like you said, like intergenerational trauma, like there's, you know, tons of issues. So has that changed over the last, I don't know, 50 years? Have you seen it get better, same, worse? You know?
Well, you know, like with the diabetes was just awful, and it just seemed like we were all going to die from diabetes. And then the federal government decided to actually start specifically funding a special diabetes. It's called that Special Diabetes Program for Indians, SDPI. And instead of just saying, this is what we're paying for, they asked the tribal leaders what would help. And so the tribes actually put input to the funding, gave input into the funding. And within 19 years, our rates of not only diabetes, but kidney failure and all the other diseases related to diabetes started to go down. And so we know that when we can help direct the healthcare of our people, and I think this is important for universal healthcare too, is that it needs to be community-led healthcare. So the more that we're drawing down the funds and running our own programs and taking care of our people in the way that we know they need to be taken care of, we're getting better. We're really finally starting to get to deal with trauma. For the longest time, the focus was on poverty. But for Indian people, I don't know about other groups of people, trauma was really the issue, and that's keeping us in poverty, but it's also affecting our healthcare. And now that we're finally focusing on trauma, I feel hopeful that we're getting somewhere.
Yeah, that's really good to hear. Yeah, I'm not sure, I think these issues aren't really addressed in the news all the time. And, it's not really like seen by media, I feel like.
If you want to know the story of a tribe, you need to ask the tribe. The reporters never get it right, even if we tell them exactly what to say. It's, yeah, about us, not without us.
Okay, let's see. I think the only other question, it was back here. I think Linda was wondering where you got some of the images, like the tribal logos.
Oh, I stole those from the DCYF tribal liaison, but I sent the slides in a PDF to Marcia, I believe. So I'm hoping that she can share them out with you. And they might actually be on our website.
Yes, they're on your website.
Yeah.
You're right. Yeah, but we do have.
They're just really beautiful. Yeah.
Yeah, I really like that. Okay, well, if there are no other questions, Gigi, I will just go on ahead to the wrap up and thank everyone for tuning in tonight and for your excellent questions. It sounds like we got to every one of them, but if you have more questions, please feel free to contact us via our website, or it's probably the best way to do it, or check our Facebook page. We have a Facebook page at Healthcare for All Washington, and you can certainly enter a dialogue there. I would like to mention here that next month's topic will be lowering prescription drug prices. Please mark your calendar now and be sure to join us on Wednesday, September 8th, again at 7 o'clock. We look forward to seeing you then. And I just am really pleased that we were able to delve into the Indian healthcare system a bit, and I know there's more to learn. So thanks so much to Vicki for joining us and filling us in, and we look forward to talking more with her and with all of you. So thank you and good night.